Good morning, good afternoon, and good evening. Welcome to our launch of the new implementation guide, Improving the Quality of Care for Maternal, Newborn and Child Health, Implementation Guide for National District and Facility Levels. We're delighted to welcome you to our launch today, which is an important moment for the Department of Maternal, Newborn and Child and Adolescent Health at WHO and for the Network for Improving the Quality of Care for Maternal, Newborn and Child Health. This launch comes 5 years since we began the work with countries and partners as the Network for Improving the Quality of Care for Maternal, Newborn and Child Health. The implementation guide is a living document that has been developed from the rich implementation experience emerging from the 10 countries in the Quality of Care Network and from implementing and technical partners in support of that work. Today, we are joined by Ministries of Health and partners to share their experience and lessons learned in implementing quality of care for maternal newborn child health programs at national, district, and facility levels, and share their views on how the implementation guide can be used. This webinar is hosted by WHO, the Quality of Care Network, and the Quality of Care subgroup of the Quality Health Task Force. We have 2 parts to today's session. In part 1, we will have the launch of the implementation guide, and Dr. Blerta Malici will take us through the guide content. Then we will hear from Mrs. Selina Doucet, Acting Head, Quality Management Unit of the Ministry of Health in Ghana, together with Dr. Frederick Adomako Boateng, the Director of Health at the Bono East region of the Ghana Health Service, and as well from Sister Einalem Legesse, Quality Officer, Federal Ministry of Health in Ethiopia, to share their implementation journeys to improve maternal and newborn health quality of care. In part 2, Martin Dalston, Technical Lead for the network, will facilitate a panel discussion of partners with both a global and a country focus. And this will be done with Dr. Sham Said, WHO's Integrated Service Department Focal Point for Quality of Care, Dr. Alex Manu from the London School of Health and Tropical Medicine and the University of Ghana, Dr. Kathleen Hill, USAID Momentum, and Dr. Minara Chaudhry, Institute for Health Care Improvement. Also, in part 2, we wish to hear from you in our question and answer session. So please place your questions in the chat box, and these will be posed to the panelists. Finally, we will close the session. So coming to the first part, and I'm delighted to be here to launch this guide. Why do we need this guide actually? Despite significant increases in access and coverage of health services for mothers and children, we still have a staggering number of women and newborns who face sickness and death during and after childbirth. We now know that having access to health services is on its own not enough to reach the Sustainable Development Target goals, goal targets of reducing maternal and newborn deaths. We also know that most maternal and newborn deaths and stillbirths can be prevented with good quality care. The Lancet Commission for High Quality Health Systems estimated that approximately 100,000 maternal deaths, 1 million newborn deaths, and 1.5 million under 5 child deaths, and 1 million stillbirths could be averted each year through improving the quality of health systems in low and middle income countries. In addition, quality care is a key component for addressing health system inequities and inefficiencies, improving accountability, and providing dignified and respectful service delivery. In 2019, the United Nations General Assembly adopted the United Nations Resolution on Universal Health Coverage, which addresses the urgent need for action for universal health coverage with quality care. However, we know quality of care does not occur spontaneously. the challenge to deliver quality care is faced at all levels, whether national or at district, as well as at the level of health facilities. Health systems performance and health outcomes rest on all stakeholders. More investment is needed to consolidate the foundations of health systems, improve the engagement of communities to define and deliver quality care for mothers and newborns, and cultivate a quality culture within and among health managers and the broader health workforce. This implementation guide contains practical guidance for policymakers, program managers, health practitioners, and other actors working to establish and implement quality of care programs for maternal, newborn, and child health at national, district, and facility level. It is intended to help anyone throughout the health system who wants to take action to improve quality of care for maternal, newborn, and child health. By working together to improve the quality of healthcare for women and children through all levels of the healthcare system, from national level down to community level, we can help build a healthier, safer, and more equitable world for all. This guide was developed by the Department of Maternal, Newborn, Child, and Adolescent Health and Aging at the World Health Organization and informed by the 10 countries in the Quality of Care Network, and particular acknowledgement should go to the 240 participants at the second meeting of the Quality of Care Network in March 2019, who provided extensive inputs to the formation of the guide throughout the workshop sessions. Special thanks in particular goes to country teams from the 10 member states in the network, and they're listed here, as well as to our partner organizations who have really supported this work jointly with us at country level. And I would like to specifically also thank Tedbabe, Haile Gabriel, Pierre Barker, Kathleen Hill, Nigel Livesley, and Sonali Vait for their inputs into this guide. Thank you all very much, and I now hand over to Blerta Mlici, the lead policy, strategy, and programs advisor at the Maternal, Child Health and Adolescent Health and Aging Department in WHO, to present the implementation guide.
Thank you very much, Anshu, and good morning, good afternoon, and good evening to all participants who have logged in this webinar. In the next 15 minutes, I would like to provide you with an overview of the implementation guidance, some of it, where it started from, its core principles, what it's trying to do to help, as well as how to go about using it in your day-to-day work. Next slide, please. So the implementation guidance started with the development of the network for improving quality of care for maternal, newborn, child, and adolescent health. The network is a broad-based partnership of committed governments of 10 countries, implementation partners who are engaged with these governments in improving maternal, newborn, child health results through a quality of care lenses, as well as funding agencies and partners who believe that addressing quality of care and improving quality of care for maternal, newborn, and child health will help us to make that quantum leap and achieve the sustainable development goals. The question that the network countries tried to address in its beginning in 2017 was how to implement quality of care at scale and in a sustainable way. In this, with this idea in mind, the 10 countries and partners of the network articulated the 4 strategic objectives of the network, that of leadership, action, learning, and accountability. They'll be the strategic levers that will help countries and all of us to achieve a vision in which every pregnant woman and newborn receives quality care, through which we can half of maternal and newborn deaths in health facilities, and improve our experience of care for all women and babies. So next slide, please. Following from this beginning, everybody around the network, so those 270 participants during the meeting, but beyond that, over the last 5 years, over 700 different participants, partners, and implementers from across the 10 countries. They all together they put their wisdom and said that we all in our countries do have quality of care programs. We have started many of them don't finish. However, we know how and what needs to be done. So, and basically that is what they articulated in the country-led implementation approach or broader implementation approach to quality of care. So this implementation approach is underpinned by principles of government leadership and stakeholders partnership. It's an approach that emphasizes the need for an overall strategic direction for quality health services, so beyond MNCH, but at the same time it recognizes that using MNCH as an entry point can tell a country and a government how well their quality of care policy, strategies, and implementation are functioning. The implementation approach also emphasizes the need to use and share data to guide implementation, monitoring, and progress, accountability of progress, supported by a clear quality improvement based on plan, do, study, act cycle, but also supported through a learning network that cuts across all levels of the health system, from the national and policy-making level to the front line of service delivery and exchange with communities and patients. Next slide. So using that implementation approach and using the 5 years of implementation experience with all countries, as a secretariat in WHO and along with our partners, we try to pull together in a more systematic way that learning experience that has informed the development of the guide that we are sharing today. So what is the purpose of this implementation guidance? And I'd like to say that is implementation. So it focuses in implementation, how to make sure that we're implementing quality of care programs. So the implementation guide provides practical guidance for establishing and implementing quality of care programs for maternal newborn child health at national, district, and facility level. I should say that the same principles apply to all programs, and that as WHO, we have uplifted these principles and this implementation guidance in a broader guidance to guide all programs on how to implement quality of care across the 3 levels. Next slide, please. This slide, so who is this implementation guide for? This implementation guide addresses the needs of national policymakers and legislators, so all those who are in charge of developing the policy strategy, but also deciding about its organization, program managers and technical staff at national, district, and facility level, so those who are in charge of organizing, allocating resources, managing and implementing the programs. Healthcare practitioners working in MNCH, the quality of care changes and is improved at the point of care, point of delivery. Therefore, it is for healthcare practitioners who are really addressing and putting all their skills and competencies in delivering that type of care that is of quality. And any other actors also working to establish and implement quality of care programs at the national, district, and facility level. Next slide, please. As I already said, implementing quality of care actions and strategies is not new. While the implementation guidance calls for a whole system approach, it also provides a starting point for countries and implementers to build on what already exists and to continue to advance their quality of care agenda. So this knowledge it is this knowledge that has informed the guiding implementing principles of this guide. And it is based on these principles or through these principles that we hope to empower the implementers to get started quickly, set the tone for their efforts, and hopefully foster positive culture for quality of care improvement. I'll spend a few more minutes just to go through those principles because they are important to all implementers. First of all, don't hesitate. So quality of care is not simple, it's not easy, it takes time to improve quality of care. However, do start fast. Keep it small and simple. So build on what already exists and make sure to advance that existing agenda through your existing plans and documentation. So that is starting small doesn't mean being focused or just piloting. It means having the possibility to learn and adapt in order to scale up across a national, subnational, national level. Focus on health outcomes and patient experience. This is about improving quality, and quality is the aspect that improves the patient outcomes and experience. For those of all of us who are working on maternal, newborn, and child health, link those outcomes with the targets of the INAP, EPMM, child health, or even adolescent health programs. So keep your focus and your target on what needs to be changed and achieved. Build on existing structures and functions. All countries may have or not quality of care structures. It's good to have those quality of care structures because they take the burden of organizing the quality of care across health services. However, the implementation of quality of care programs does not belong only to one single directorate or place. It belongs to all the actors who are delivering health services, organizing health services, and working for them. Therefore, building on existing structures, developing new structures, but most importantly, making sure that all structures that are working on quality of care work together and deliver on the same goals is the most important principle for implementation. Change systems to support health workers. We know that our organization and management systems are not perfect. Many of them needs to be adapted to allow health workers to do work differently in order for them to achieve the goals and targets, but also to deliver care with quality, which is not only technical, clinical quality, but is respectful care. So let's provide the health workers and the manager, the frontline providers with systems or opportunities to change systems to make them suitable to deliver on their work. And finally, the most important, learn, adapt, and share. Quality and quality improvement are based on principles of adaptation, learning, and sharing. Building a system that allows for quality to improve at scale and in a sustainable way is based on a learning system that spans across all the levels of care. And I will go into that in a few minutes' time. Next slide, please. The guide calls for 5 integrated systems that are required to implement quality of care. And that is the on-site support, which means basically organization of the systems around quality improvement to allow health workers to think critically, use their data, set their improvement areas that influence those outcomes, health outcomes that are so important. We said is one of the driving principles of the implementation, and allow them to track their improvements in a way that this type of improvements and changes become part of their routine processes in a way that do improve results in the longer term. The second aspect is that of learning and sharing. So learning and sharing within teams, across teams, within organizations, across organizations, and within districts or regions and across all of them in such a way that it allows that learning to be used not only for decision-making at the point of care, but also to be used for decision-making in terms of service organization, resource allocation, target setting, and moreover, policy development and setting, guideline development and adaptation in a way that makes sense to the context of the country. Measurement, there is no quality without knowing what we have improved and how we have improved it. And there is no quality that is not delivered for the communities and users of the quality. Hence, that community and stakeholder engagement is the most important system that defines not only what quality is, but also that allows us to keep ourselves accountable in the way on how that quality is delivered. And finally, you need program management. All these aspects they need to be managed, built in the existing systems and structures, ensure that they are happening in a way that it allows quality to continue across all the levels. So with these 5 systems in mind, next slide, please. I'd like to take a few more minutes now to focus on how this guide is organized. So we do have the guiding principles, we do have the systems that need to be in place. We know what we have to deliver, so what quality is and how to go about it. But now, what does it mean to implement, to ensure that this implementation is happening all the time? The guide clearly calls for 3 levels of implementation. National level, meaning the policy development, the strategy development, the macro resource allocation and thinking, as well as the macro target setting for all the country. The district level, or that level at the subnational level that is in charge of organizing, directly organizing service delivery. That is closer to the facility and community level, but at the same time, it is that level that is responsible for making sure that the action is happening. Basically, quality will take place. And then finally, the facility level, so where the real action, the interaction with the patient and user is happening. The point of care is the point in which quality is changed. We can speak in a webinar, but this will not change the quality, only if the service provider will change the way or will improve the way on how he or she is providing services. That is the moment in which quality will change. So focusing at the facility level and providing all the levers as well as actions that need to take place at that level to ensure that quality is delivered, that is the other part of the third element. For each of the three, so the guide is organized in these three levels, detailing the actions that are required to facilitate the implementation. The three sections of the guide can be used independently, that are not dependent on each other. And that is done in purpose because someone who works in one of the levels may not, or let's say a provider at the facility level, may not need to do all the actions that are taking place at the national level. So, but still that provider can take action to change quality in her or his facility. At the same time, a similar thing can be said for district and national level. So there are the three parts. They are organized in such a way that they can operate independently, but the best it is if they are embedded in a national program that covers all the three levels. Activities in each section are divided in startup. So what needs to happen to establish or to the environment, and those that are to sustain, so actions to sustain the implementation. So how do you build the environment in such a way that it continues not only at the beginning or when you start very happy that something will happen about quality, but how to sustain and mainstream it in the implementation of organization of health services and systems. Finally, each of the section provides a link to useful resources, so additional resources on what you may need to use to establish that level of to establish the different organization systems and structures for each of the three levels. So next slide, please. I'll only go through the key activities that are required for each of the levels. The details are in the guide. So as I said, so you'll see three similar slides on the national level, district and facility level. For the national level, the beginning is a startup activities of establishing the environment in which quality of care at a macro level needs to take place, bringing all partners and resources together, and so on. And the ongoing activities, they will focus mainly on fostering the environment for strengthening the implementation, but also making sure that all the targets are mainstreamed and built in the national plans and strategies. So all the health system follows and pursues the same target, especially when it comes to maternal, newborn, and child health. Next slide, please. At the district level, the focus of activities is mainly operational. So it is making sure the startup of activities, not only the orientation of the districts and its partners, but also making sure that we are building on the existing systems, that we are starting to use the initial review and resource allocation systems and accountability systems in such a way that they do give more information about quality, but also quality on the center. And the ongoing activities are exactly those type of activities that allow the implementers to mainstream quality of care in the day-to-day processes, including those, as I already mentioned, resource allocation, but also supervision, mentoring, training, capacity building of the health workers. Next slide, please. At the facility level, and this is the only part of the guide in which the facility level activities are organized in two parts. One, it pertains more to the management and organization, and the second, it pertains mainly to the implementation of quality improvement activities. So the QI does happen at that point of care. So again, on the startup of activities is the orientation, the mainstream, and preparing for mainstreaming quality improvement activities and the on-site support at the facility as part of the facility activities. But when it comes in terms of the ongoing activities, a lot of it has to do with change management and bringing forefront an organizational culture that supports and improves quality of care. Next slide. So second part of the quality improvement activities at the facility level talks mainly to the quality improvement and how to go about establishing and how to go about supporting its implementation. This part builds and links immediately with a key document prepared and developed by our colleagues in the Southeast Asian region on quality improvement, which is point of care quality improvement. And that is the guide where you'll find all details on how to go about the implementation of the quality improvement activities. And finally, in the implementation guide, you will find a number of annexes. Next slide, please, which cover the different, or give you hints on how to go about organization and the different steps that you need to undertake to understand your situation. So where the country, where the district, where the facility is, in terms of quality and quality improvement, how to go about prioritizing the key activities that need to be built in, and then of course how to link, either to link or to inform or to strengthen processes such as that of a development or update of a national quality policy strategy, development of a measurement, most importantly, adaptation and implementation of standards of care across all levels, but also preparation and sustaining all the activities required for quality improvement, especially those around using tutoring of quality improvement and coaching around quality improvement. Now, those are activities that are in relation to quality improvement and quality. The guide provides a clear list of MNCH specific activities that link directly to the implementation of the guidelines and strengthening the implementation of those guidelines that cut across from the introduction and implementation of new technical guidance into institutionalization of processes that improve quality and accountability, such as those of maternal and perinatal death surveillance and response, or specific processes that deal directly with this implementation. Next slide, please. The guide is supported by 3 additional documents that go more in depth. The first it is, next slide, please. The first is in relation to learning, and we already, next slide, please. We already discussed or mentioned that it's in guidance. The process of learning is very important, but how to go about organizing and implementing. We do have now a smaller guide on establishing learning systems for quality of care that clearly identifies what needs to be done in each level to ensure that that type of learning is effectively implemented, but also influences on processes that are needed and required to deliver quality. Next slide. The second supportive guidance is that in relation to integrated community and stakeholders engagement. Next slide, that is an online tool as well as the booklet. The guide goes and brings together different experiences and ideas around bringing stakeholders together to influence and define quality, but also to maintain accountability along quality. And is reflecting the experiences of all countries on this area. And finally, next slide, we do have put together a guide on measurement of quality. This is a piece of work that is ongoing. It will take another few years to get into a mature level on how to go about measuring quality of care for maternal, newborn, and child health. Next slide, please. However, the guidance is quite strong and it provides a good framework around how to think through quality. What is it more routine vis-a-vis what is more based on quality assessment and what is required to do so. Finally, as I already mentioned, next slide. At the end of the guidance, you'll find a list of supporting tools or across maternal, newborn, and child health that are interventions that allow us to create these systems environments, to reduce harm, improve clinical interventions, and address all patient, community, family, and community engagement around maternal, newborn, and child health. And in a way, it provides also the links across the different pieces of work that all maternal, newborn, child health programs do with what the broader quality of care programs provide as a facilitator and enable environments. Last one. So I think with this, I would like to thank you. This was a very quick brief, but I would like now to hand over to Martin, who will take us through the country presentations and how this type of guidance basically has been applied at the country level. Martin, over to you.
Thank you very much, Berta, for this excellent overview of the guide. So as a next step in this webinar, we will move on to hear from about some network country experiences. So next slide, please. So as mentioned before, we will hear about implementation at national level, the experience and lessons learned from Ethiopia. And this will be presented by Sister Anyalem Legesse, who is the Quality Officer, the Health Service Quality Directorate at the Ministry of Health Ethiopia. And then we will also hear about implementation at the sub-national level, experience and lessons learned from Ghana. And this will be done by Ms. Selena Duse, the Acting Head Quality Management Unit at the Ministry of Health Ghana, and also Dr. Frederick Adomako Boateng, the Director of Health Bono East Region for Ghana Health Services. So next slide, please. So with that, I would like to hand over to our colleague, Sister Anyalem Legesse, for the presentation from Ethiopia. So over to you. Thank you.
Good morning and good afternoon and good evening, everybody. I'm Anyalem from Ethiopia, working at Health Service Quality Directorate, Ministry of Health. I'll present experience and lesson learned from Ethiopia. This is my presentation outline. It includes introduction about maternal and neonatal health, general information, national strategy and implementation approach, and then I'll present the MNCH a roadmap, strategic objective implementation, and then I will present lesson learned and a recommendation. Next slide. About the maternal and neonatal health situation in Ethiopia. Ethiopia achieved substantial progress in maternal and child health mortality reduction. Ethiopia meets the Millennium Development Goal target as 3 years earlier by reducing under 5 mortality by 67% and a significant reduction in maternal mortality. However, there is a slow rate of reduction in neonatal deaths. So, as a challenge, there is a stagnation in neonatal and maternal mortality and reduction. It is still, there is high burden of neonatal and maternal mortality. According to MNCH, Ethiopia, the national, the neonatal mortality is around 30 per 1,000 live births, and maternal mortality rate is around 400 till per 100,000 live births. It is still high. As an opportunity, there is increase in maternal health coverage. 74% of pregnant women receive ANC, one visit from a skilled provider, and from this 43% of a pregnant mother received ANC visit 4 or more times. Regarding the institutional delivery, 48% of mothers attend their delivery in health facilities, and 50% of mothers assisted attend their births by skilled birth attendants. In addition, 34% of mothers received pregnancy checkup in the first 2 days after birth. Therefore, to improve maternal health, integrating quality of care is very important. When we see the national policy and strategic framework, Ethiopia prior to WHO quality of care network, Ethiopia developed national health sector transformation plan and RMNH strategy aligned with this health sector transformation plan, she developed the National Healthcare Quality and Strategy, and MNH was the priority in HSP1. In the strategy, there were 5 priority areas identified. One of them is MNCH. This created an opportunity for Ethiopia to join the network to improve quality of care for mothers, newborns, and children in 2017, followed by MOH leadership and active support by the network partner. A national MNH quality of care roadmap was developed. This roadmap has, next slide, please. This roadmap has 4 strategic objectives: LALA, or leadership, action, learning, and accountability. The key elements of implementation approach at national level: the national government took the lead in the development of strategic direction and structures. That was one of them is maternal and newborn quality of care become one of the flagship large-scale quality initiative. It is taken as a flagship initiative for 2 consecutive years and followed by the ministers. So this creates many opportunity for the learning health facilities. In addition, engaging the network partners with defined roles, commitments, and responsibilities. Advocacy was made using the MOH website about the national health care quality, the national MOH quality initiative using the MOH website. At regional level, all the regions have made efforts to adopt and adapt contextualized regional roadmap. At district level, district-based improvement collaboration was established, and this MNH quality of care initiative was implemented in 9 regions and 1 city administration. It has a total of 48 learning health facility, 8 referral and general hospital, 12 primary hospital, and 28 health center. It is represented from agrarian, pastoralist, and urban context. Next slide, please. Leadership in the structure. Ethiopia made so many achievements to establish a quality structure at national and sub-national level. At national level, there was Health Service Quality Directorate. It is established in 2060, and in addition to this directorate, a steering committee was established at MOH that support all QY activities in the directorate, and also there is a QY coordination structure established at national and sub-national level. Model for improvement in Kaizen 5 is taken as a QY model at district and national level. National measurement system strengthened efforts to integrate QY indicator in the HMIS, taking data from facilities and districts to regions and national level for a review. Next slide. At regional level, there is a QY case team under creative and rehabilitative for process owner, and just like us in national level, there is a regional QY/TG that support QY activities in the region. At district level, in some regions, there is a QY case team, but in most regions, there is a QY focal, to QY focal in the district level. And all 14 MNH QC districts have one MNH QD focal assigned to implement the MNH QC initiative. Action, Ethiopia adopted the WHO standards, MNH quality of care standards, and she developed health service quality, health service transformation for quality audit tool for hospital using the WHO framework. It has 10 thematic area. One of the chapter is MNCH. So hospital use this audit tool to assess their service area and develop QY projects depending on the findings, audit findings. In addition to this, there is a district-wide learning collaborative operationalized facility at facility level. There is a QY directorate, quality and clinical governance unit established and led by general practitioner. In addition to that, all departments that work in hospital have QY team who are responsible for conducting audit and implementing QY projects. In health center, there is a QY focal person and PMT performance monitoring team served as a QY committee and a QY team at the health center who run the quality activities, all quality activities in the health center. Next slide, please. Mentorship and coaching system established at district level, and coaching guide developed, 2 rounds of coach training provided for this MNH quality of care health facilities. In addition to this, regarding the capacity building, TOT and basic QY training is provided for this health facilities. Baseline assessment conducted in each health facilities before implementation, and the strength and maternal days audit and the response in the facilities to strengthen the MDSR for MNH quality of care in implementing the facilities. Training provided, 4 rounds of training, MDSR training provided for QY and MNH team. In addition to that, data tracked from APHI and the Common Core Indicator and DHIS2 triangulated, and if there is any discrepancies, feedback provided for health facilities from regional health bureau and MOH. In addition, periodic quality of care assessment using audit tool. As I said before, Ethiopia developed 2 types of quality.
Sorry, Sister Ainalem, we're running a bit over time, so if you could maybe wrap up in a minute or 2, that would be very helpful.
Sorry?
Yeah, I'm just saying that we're running a bit over time, so if it's possible to maybe wrap it up in 1 or 2 minutes, that would be very helpful. Appreciate it. Sorry for that.
Sorry, I will continue. Periodic quality of care assessment using audit tool is conducted every quarter using HSTP audit tool for hospital, and there is a clinical audit tool for health centers. Okay.
Yeah, so if you can please wrap it up in 1 minute.
Develop their own change idea depending on the gap identified from the audit tool and tested these change ideas by QY team using PDSA cycles. Partner project staff worked alongside with district coaching teams on site visit, provide support QY team as they develop and test change ideas. Next slide. Learning and accountability. Ethiopia adopted WHO MNCH quality of care, MNE framework, and there are 50 common core indicators that measure provision of care, experience of care, and WASH. Use MPDSR data to inform quality improvement efforts in the learning health facilities. DHIS2 and data quality training provided for the MNCH health facilities, including orientation on common core indicators, integrating key MNCH quality measure into routine HMI systems. 3 of them are integrated, the others are underway from the common core indicators. A regular MNCH QAC indicator collection collected by health facility and collection and reporting takes place by health facility, and analysis and feedback provided from the MOH and regional health bureaus. There is a community engagement in introduction, community scorecard system, and town hall meetings conducted regularly by annual national MNCH QAC learning collaboratives conducted nationally. During this time, all health facilities, MNCH quality of care health facilities are participating actively. During this time, they share their experiences, and if there is any best experiences, they will share using that platform. Annual quality summit has been conducted every year, and annual quality bulletin produced during the summit. MNCH quality of care health facilities will publish their successful QY projects on this quality bulletin, and they are also active participants on the summit. Next slide.
Sorry. If you can please wrap this up in 30 seconds, it would be very much appreciated.
Sorry, lesson learned. MNCH quality of network implementation has shown promising results with respect to reduction in institutional mortality outcomes, like there is high reduction in significant reduction in neonatal mortality and maternal mortality after we implement this initiative. In addition, improved capacity at national, subnational, and facility level and governance to deliver.
Sorry for that. There seems to be some connectivity issues. It seems that we lost Sister Anilem. But please rest assured that we will share the presentations with you afterwards, so you can also have a more in-depth look into this. So if I may suggest that we move now to the presentation from Ghana.
Okay, thank you.
Thank you very much, Sister Anilem. Thank you very much. So Oli, next slide, please. Yes, thank you very much. So let's now move on to the experience and lessons learned from Ghana. So next slide, please. Yes, Selina, over to you.
Hello, good morning, everyone. Good afternoon. I'm presenting on behalf of Ghana. I'm at the Ministry of Health. My presentation guidelines will talk about the Ghana's implementation milestone, the scaling up progress in Ghana network, the operation document to inform the operation, implementation of the strategy. We look at the leadership aspects, look at actions, the learning aspect, accountability, and then we talk about the conclusion. Next slide, please. So I will present with my colleague, Dr. Adomako. So after the global launch of the quality of care network, it came at the time Ghana has also launched its national healthcare quality strategy, which talks about improving maternal health, child health, and then newborn health. So building on the strength and mechanism that are in place, we develop a team that is the National Quality Technical Working Group that will look at the affairs of the implementation of the quality of care network, the job to improve maternal health. And so demonstrating from the beginning, what we did was to implement this in 4 regions. So our work started with the implementation of the National Health Quality Strategy, which came to support us. So 4 regions, we did the implementation. And fortunately for us, we had a very good success. And so within 2 years, we were able to scale up to 8 regions. And then now we have scaled up to all the regions in Ghana, where we have about 186 facilities at the primary health level, implementing the quality of care for maternal and newborn health. Next slide, please. So looking at our success, how we have scaled up. At the beginning from 2017, when we started the implementation, we had 44 facilities that we implemented the strategy. That is from 2017 to 2019, we have used 44 facilities at the primary healthcare level to implement and improve quality of care for maternal and newborn at that level. And then in 2020 to 2021, we scale up with the success that we had, we scale up to 138 facilities. And now from 2021 to 2022, where we are now, we have about 186 facilities that we have covered due to the success of the implementation. Next slide, please. So what has caused for this success? There are a lot of documents that supported with the success that Ghana has gained so far. As I said earlier on, we started when the Ghana Ministry of Health has launched the National Healthcare Quality Strategy, and then also the National Maternal and Newborn Health Quality of Care Strategy Roadmap and Operational Plan. And so we use all these documents, supported us to achieve what we wanted to achieve. And also, we also use the guidelines from the Ghana Health Service on the implementation of the National Healthcare Quality Strategy. And so those 3 documents initially supported us to be able to achieve what we have now, the success story that we are telling. And now leveraging on the WHO's standard for improving maternal, improving quality of care for children and young adolescents, and also improving the standard for improving quality of care for small newborn in health facilities. We leverage on all these documents, these 5 documents, to be able to achieve what we have achieved. And then also, these documents gave us the plan and the roadmap in implementing the quality of care. As I said initially, at the beginning of it, a technical group was formed where quarterly they meet to share implementation success, to update all nationally, and then implementation partners where we have done, and then what we need to do to be able to achieve the success within the 5 years. Next slide. So now I'll leave it for Dr. Adumaku to take us through the implementation at the regional and the sub-regional level, how the implementation has been, because I have talked about the national level, what some of the things that we have put in place to be able to achieve the success. So over to you, Dr. Adumaku.
Thank you, Selina. So driving our strength from a good national quality coordination, where at the headquarters, you have all the leads of the agency for the Ministry of Health there, coordinating the quality drive in the country. This is also translated subnationally, where it's replicated, especially at the regional level. Not only at the regional level, that leadership is also translated at the district, sub-district, and even into the facilities. And so the drive and the policy is given and is cascaded down to the subnational and then the district level. And not only that, there is a feedback mechanism where the data collected is fed into the national for them also to make decisions and policy. Next slide, please. So the action, what action? The first action that was taken really was to train trainers and also coaches. And this one happened at the national, regional, and the district level. And the game changer over here for the point of care was when work improvement teams, especially where there is an interface between service and the client, were trained. And that was the game changer. When this cluster of service providers understood the use of data in making decisions and the use of data in driving quality, that actually changed almost most of the indicators as we will see. So please, let's go on to the next slide. And these are some of the issues that came up. We realized that there was a need for continuous coaching across all the level of care that we give. So the national coaches on quality will come to the regional level, will impact on the regional coaches, who also impact at the district up to the facility, so that the work of the work improvement teams will be enhanced. Please, next slide. And not only that, we also have some mentoring going on, where you have some specialists also providing coaching and mentoring for work improvement teams at the point of care. And this is actually improving the audits that we do in terms of newborns and then also mothers. Not only that, this mentoring is also helping in quality of referrals that we do, whereby that will lead to improve quality of care. Please, next slide. And these are some of the success stories that you can see. And this particular one, when the work improvement teams at the point of care, using the quality improvement tools, were able to identify the change ideas that will improve increasing breastfeeding, especially for mothers, for babies who were delivered through cesarean section. That also led to the reduction in hypoglycemia in these children. And you can clearly see in terms of the run charts, indicating how there have been improvement in the processes that were leading to this outcome. And this is one of them that you see. Next slide, please. And this was a game changer in one of the district hospitals where work improvement teams were able to identify the causes of postpartum hemorrhage in mothers. And they were able to do this when they realized that they were not able to administer oxytocin within 1 minute. They brought a lot of change ideas, and that led into solutions whereby now oxytocin is available at the maternity. Women are able to receive oxytocin within 1 minute after delivery. And not only that, this has been implemented and sustained, and is part of the service delivery as one of the district hospitals. And this is the action component of the quality of care network that we are doing. Next slide, please. And not only that, to the extent that at the community level, they are even using the quality improvement tools, even in the analysis of the problems. And this is one of the examples that you can see that even community-based activities are now using the quality improvement tools to be able to address the bottlenecks or the gaps that is impeding maternal and newborn care. Please, next slide. And this is one of the issues, the action that at Tebubu, a Martin Hospital, which is also a district hospital, the work improvement teams were able to use quality improvement tools to address anemia in pregnancy. And this was just to institute a lab where they were offering the ANC services. And this has drastically reduced anemia. And this is the graph showing the action that is going on. And this change idea has also been sustained, whereby even if you are a newcomer, a midwife coming to the facility the first time, you straight away go into a practice that has been adopted by courtesy of the work improvement teams. We can move on to the next slide, please. This is comparing districts in one of the regions where we have the quality improvement work going on as compared to the other one, the one on the right is where we are not having quality of care network going on. You can see a drastic reduction in the stillbirth rate at the districts where we are having the quality improvement work going on the left as compared to that on the right. So you obviously, you can see the impact of the quality of network work going on even within the one subnational region, where some of the districts are having the activity going on and the others are not having the activity going on. Next slide, please. And this is also maternal mortality issues, where you can see the improvement in reducing maternal deaths using quality of care network. And the emphasis is now on people really looking at the process more than the outcome. And the game changer is because the point of care are into the business of delivering the service. And now they are looking at the data and looking at the processes where the challenges are coming from. They are able to address the problem at the local level, which is also reflecting in the outcomes that we see, which is passed on to the national level. Please, let's slide. And this is the learning forum that we have created. Subnationally, there is a vertical learning going on where districts are able to share lessons that they have learned, even within a region. And not only that, we have created a forum whereby you have all the other agencies coming together and people sharing the beautiful work that has been done for people to adopt or adapt the change ideas that are being practiced somewhere. And at this forum, you have the researchers, you have all the 16 regions of the country, you have policymakers, and even you have all other agencies where people are able to learn and are able to pick where these other changes are also going to inform policy. And these are some of the learning forums that we have. as part of the quality network that we are doing, we have days where we go and share works that we have done across the country. And these are forums where ideas are easily passed on to the others. Please, next slide. Not only that, there is a bulletin that is coming out of the work that we are doing, and I think this is shared across the whole world. And these are some of the bullets that have been done based on the work that we have done subnationally and nationally in country. And the pictures that you are seeing actually came from the work improvement teams that were done across the country. Please, next slide. Research, we have been able to also provide evidence through research that we have done. And these are some of the research that we have done, conducting situational analysis, not even only the public, even to the private, whereby we'll be able to assess the level of quality of service they deliver. Interviews conducted, research done. So these are the things that we have been able to do so that it will inform learning across the country and across the globe. Please, next slide. Accountability. The service providers are now accountable to the communities which they serve. And how is this done? This is done through scorecards, where the community themselves, community health management teams will come into your facility, assess you in terms of how you are delivering your service. Together, you come with the gaps, and then you inform how you are going to address the gaps. And this forms the basis for accountability for where the practice, the networks are. And not only that, these scorecards are sent regionally, nationally, as a form of accountability, all leaders across board. And this is what the accountability is provided. To the extent that some regions which are in this have been able to bring in the regional directors, district directors, medical directors to be accountable for the services they provide through appraisals and performance contracts that they do. And once you are able to translate this at the leadership level across all, translating this at the point of care becomes very easy. This is the form of accountability quality of care network has provided for the country we in. Please, next slide. The opinion leaders, chiefs are all holding us accountable for the work that we do. And not only that, through the things that they come and see and witness, they are also held accountable, and they even decide to provide some of the services that we need. And these are what are going on in the country. Next slide, please. This is a regional director appraising district directors and medical directors, holding them accountable for quality of care that they are supposed to do. Next slide, please. In conclusion, Ghana Network for Improving Quality of Care has built a committed national and subnational leadership structures. And these are there to stay. In terms of action, we have used the WHO standards of care. There is sustainable efforts put into the point of care. There is a coordinator coaching system, which has ensured quality provision of care in all. And not only that, based on this, some regions have decided to train regional coaches to support the regional and the district teams. And learning, Ghana has treated learning forums using existing national and subnational platform. Accountability, health care workers are held accountable to the community. Gains are being sustained through institutionalization of national quality structures and scale up through partnership with donors. Next slide, please. Thank you. And these are all the partners that are making sure that we deliver quality of service to the citizen and making sure that there is universal care coverage with quality. Thank you.
Excellent. Thank you very, very, very much for both excellent presentations from Ethiopia and Ghana, which really touches upon the various important aspects around setting up systems for quality of care, MNCH, at the different levels of the health systems. And I think it also resonates quite a lot with the content in the implementation guide, which was presented by Berta before. So as a next step in this webinar, we will now move on to the panel discussion. So next slide, please. Thank you very much. So I'm very pleased to have the pleasure to facilitate this panel discussion. So it will be with Ms. Minara Chowdhury, the Senior Director for Institute for Healthcare Improvements. We have Professor Alexander Manu, the Associate Professor, Maternal Newborn Child Health at London School of Hygiene and Tropical Medicine. And then also Kathleen Hill, the Senior Technical Advisor for Quality at the USAID's Momentum Country and Global Leadership in JAPIGO. And then last but not least, Dr. Sham Saeed, the Quality of Care Unit Head in the Department of Integrated Health Services in WHO Geneva. So I would like to start off with building a little bit upon the presentation from Ethiopia and zoom in a little bit more on the national level and the broader quality agenda, which looks beyond MNCH. So I would like to turn the attention to Chance with the following question. How does this implementation guide for maternal, newborn, and childhood links to the broader quality of care guidance, and particularly at the national level? And what additional benefits would this guide bring within the system's perspective? So over to you, Shams.
Yeah, thanks so much, Martin. And just first of all, congratulations to the team and as well the country colleagues for all the work that they've been doing. Really great to see the launch of this implementation guide for quality of care for maternal, newborn, and child health. And maybe, Martin, as just going back to something that Berta mentioned in her introduction, and coming through from actually the insights from our colleagues in Ethiopia and Ghana, this work, of course, links very closely with efforts on broader quality of care across health services for all populations. And WHO, as Berta had mentioned, has indeed released a planning guide for quality health services as a whole that has been actually informed by the experiences of the QED network. So here's where the focus on the population and the focus on the entire population comes in hand, and it came out really beautifully in the descriptions from our colleagues in Ethiopia and Ghana. And many of you will be familiar with the guide, which focuses on actions required for quality of care at the national, district, and facility level for the entire service. But this, if you can see, the bridge is very clear between the MNCH guide and the guide that focuses in on overall health services. And particular point of emphasis is the national strategic direction setting on quality of care. And as Ethiopian colleagues and Ghanaian colleagues highlighted, the national strategic direction setting on quality of care is really critical. And that can have a spotlight on high priorities such as maternal, newborn, and child health. So just to re-emphasize that the technical resources from WHO are completely aligned to ensure a health systems approach to actions by countries. And these links are actually quite critical to consider. And in particular, as these efforts to have primary healthcare driven work towards universal health coverage. And as many of you will be aware, WHO and UNICEF does have a PHC operational framework that focuses in on systems for improving quality of care. And today is a really important moment where the focus on the population, MNCH population, comes hand in hand with efforts on health services in its totality. Martin, thank you.
Excellent, Chance. Very interesting. Thanks a lot. And thanks a lot for also the linkages with the whole primary healthcare and USG agenda, which is very important to stress. Without losing time, let's move to the next question. So we've seen also now that the implementation guide mentions that one of the 5 integrated systems to set up quality of care MNCH program is learning. Which we saw wonderful experiences shared from Ghana, and we also heard in Berta's presentation the critical importance of a national learning system as a core mechanism to share learning from facilities to districts, which will then inform the national planning. So I would like to pose a question to Alex. Based on your experience in implementing QOC programs, could you outline any key components required to set up a successful learning system that can actually generate and share lessons, learnings across the 3 levels of the health system? So Alex, over to you.
Thank you very much, Martin. And I just want to re-echo the voice of Shams in saying that I'm really happy to see this launch today. And it's really, really enlightening to hear from our country colleagues in Ethiopia and Ghana. So I see quality improvement and quality of care improvement in facilities as a journey. And when I was young, I used to sit in my grandmom's car and we traveled from the town, the village in which I was to the capital city. And on the way, she tells me to be looking around to look at things, read signposts, and look at colors of buildings, and we make comments on that. But what am I saying? For us to move from the village to Accra, there needs to be a driver. My grandmom was asking me questions and we're discussing. Quality improvement, one of the key requirements is a driver, leadership. If you want to share from learning from the facility level to the district level or rise even higher, right in the middle of that, you need a driver. The driver must be somebody who is committed to the cause. That driver doesn't need to be the highest person in the district or the region or at the national level, but it should be somebody who is committed and has the support of the highest people so that they can leverage that support to get people on board. So one, you need leadership, a driver. The second thing is that my grandmother created that non-intimidating platform within the vehicle for us to be able to have the discussion. So if you have a learning platform, that learning platform is critical. So whether it's virtual, whether it's in person, that platform must be created. A platform on which people can ask questions freely without feeling embarrassed. And a platform where people can, and from Namibia, UNICEF support to Namibia, they have this mantra that you should copy shamelessly, but implement wisely what is working and what is not working. So it should give you that ability to copy shamelessly from each other. So that platform is always needed. The third thing about this platform is that it must be created in such a way that hierarchies are dissolved. So that's the third thing. Dissolve all hierarchies. You meet on the platform, you should be colleagues. It shouldn't be, the doctor has said it, so a junior colleague cannot challenge what is being said. It's a learning platform. Allow learning to flow freely on such a platform. That is when you can make an impact. The fourth thing is that this platform must have some regularity around it, whether it's monthly, whether it's quarterly, whether it's half yearly. There must be some regularity around it and allow everybody to have that expectation about coming to learn on that platform. The fifth thing that is important is time allocation. Sometimes you go for this learning platform and you give somebody 5 minutes to tell us what they have done, best practices from their facility. Nobody's going to learn from that. There's always that need to then balance what is quality to what is quantity. If you need to select 2 facilities, like we did today, 2 countries, and saying that they should present for us to learn, there is more in-depth learning from getting 2 quality sharing sessions than having everybody present something when we learn nothing from others. So there's always that timeliness, and you need to think about the time allocation for people. It must be enough for people to learn. The 6th one is recognition of baby steps. It's not everybody that will be leaping and galloping. There will be some people who will rise and start crawling and fall again. But even in their crawl, the little steps that have been taken, they must be appreciated. They are also there to learn. So if you recognize those baby steps in those learning experiences, people are challenged to do better. So that is another key ingredient that you must have in the, and the last one, which is the 7th, is a clear documentation for follow-up. because after the learning sessions, people will want to follow up on some of the best practices they had to learn how to implement them. And when they are falling along the way, how they can rise again. So you must always have a clear documentation of the learning process and share with the learners so that there can be cross-fertilization of the learning. There could be so many that I can say, but these are the 7 key ingredients that I want to share on this platform. Thank you.
Thank you very, very much, Alex, for these interesting insights. And I actually allocated a bit more time to you because that's also what you mentioned. But really great to hear also these personal sharings and that your grandmother also have influenced your thoughts around this. Thank you very much. So let's move to the next question. And another part of the 5 integrated system for QoC is monitoring. So now let's dig a little bit deeper into the importance of a monitoring system for QoC MNCH, especially at the national level. And this is also one of the critical aspects for a functioning quality of care program that will guide the quality improvement to inform what areas to address, where to focus the efforts, and also if any progress is being made. So I would like to ask Kathleen, if you can please reflect on the importance of national level monitoring frameworks for quality of care and how this implementation guide can be used from a measurement point of view at national level.
Thank you very much, Martin. And just to begin by thanking you for inviting me to be on this panel and also echoing my co-panelists in thanking our colleagues from Ethiopia and Ghana for really inspiring and comprehensive presentations that I think really illustrate the key concepts laid out in the implementation guide. So I'd like to begin by emphasizing the importance of quality of care measurement along with change management as a core element of all healthcare improvement, wherever one is implementing interventions to improve quality. And as mentioned by Blerta and as highlighted in the implementation guide very wisely, I think, measurement is one of several interrelated functions essential for large-scale quality of care programs. And the regular measurement of quality of care is vital both for informing the daily work of QI teams to improve care on the front lines, what is sometimes called point of care QI, and it's also vital for the effective management of quality of care program activities across system levels, so that quality of care measurement is everybody's business in a sense, who is participating in improving large-scale improvements in healthcare. And as many participants in this webinar know, quality of care indicators building on the Donabadian quality of care measurement framework typically include input indicators, which measure service delivery readiness, availability of key commodities, competent health workers, et cetera. Process measures, which measure processes of care and the organization of care, and outcome measures, which measure people's health status or experience of care. And as we know, of course, improving health outcomes and experience of care is the North Star of quality of care programs. And I so appreciated the example from Ghana of reducing rates of anemia in pregnancy. Anemia is a complex condition, and it's really impressive to see those outcome results. So the implementation guide helpfully recommends the development of a national MNCH quality of care monitoring framework and plan with priority indicators, which it can be very useful as I think we've already seen for organizing the work at national level. And one useful resource along with the implementation guide for national stakeholders that is referenced in the implementation guide and was mentioned by Blerta is the monitoring framework of the Network for Improving Quality of Care for MNCH. And this framework the monitoring framework published in 2019 outlines 4 categories of measurement based on the specific quality of care measurement needs of key actors at national, subnational, and service delivery levels. So just as the implementation guide outlines key activities, structures, needs at national, subnational, and service delivery level, I think we could probably agree that not all actors at all levels need exactly the same quality of care have exactly the same quality of care measurement needs. And it can be useful to really think strategically about what are the measurement needs of key actors across system levels, depending on the key functions and that they're playing within a broad quality of care system and program. And within the monitoring framework, there are 4 categories of quality of care measures that are hypothesized, and this is very much a work in progress, but I think we've been really learning and testing this as part of the network rollout in multiple countries. And the first category is a set of core quality of care measures that are relevant for all actors across all health system levels within a country. Regional district performance measures that are focused on the needs of regional district managers, QI measures that are mapped to the individual quality statements in the adapted national standards for improving quality of maternal newborn health, pediatric and young adolescent, and small and sick newborn. And these are really for use by frontline QI teams who are working to achieve specific quality statements or aims within a particular phase of improving care, because of course, quality improvement is never ends. And then also very importantly, quality of care program implementation milestones or quality of care program process measures, which can be used and are very important for national and subnational managers to monitor whether or not program activities are being implemented as planned and to guide ongoing adaptive management. And ideally, the core.
Sorry, Kathleen, sorry to interrupt you. 10 seconds, please.
Yes, okay. Let me just finish up. I was going to mention, but I know we're very short in time. I was going to mention that in Nigeria, there has been the development of a national quality of care monitoring plan that has been jointly led by the Department of Planning, Research and Statistics and the Federal Ministry of Health, Family Health Division, and that this has helped to shape a strong national MNCH quality of care monitoring plan and to foster co-ownership and collaboration for ongoing implementation of this plan. And the M&E subcommittee of the National Quality of Care Technical Working Group works together, I think, very effectively to help oversee implementation of the national plan in Nigeria. I'll pause my comments here. Thank you.
No, thank you very much, Kathleen. There's so much interesting stuff going on, and we wish we could let you speak for forever around this. So sorry for that interruption. But just to move forward, so we heard some great reflections and experiences, especially from a national level of the health system point of view. Now to continue, I would like us to shift focus a little bit and zoom into the more subnational and facility level components, which is important to take into consideration too. So to start off, I think no one is better suited for this than Minara. So Minara, could you please reflect on the implementation challenges that could be experienced at subnational and facility level from your end? So over to you, thanks.
Sure, thank you, Martin, and congratulations to the teams in Ghana and Ethiopia for some fabulous presentations, and thank you everyone for listening. I think there are many challenges as we embark on implementation of quality improvement, and perhaps the most important challenge is fatigue. Fatigue amongst staff members, service providers, amongst leaders, as there are so many different improvements that need to be made to a system. And in doing so, there's this tiredness, this fatigue of how do I move beyond this? How do I get into a point where we can actually improve? That coupled with the desire to get results, early results, quick wins are great, that's brilliant. But to then move that into sustainability takes a lot of effort. And for that, we need motivated and dedicated staff. So the challenges are at a system level, if there's a lack of strategy, if there's no direction, that also impacts on a facility level implementation. So when we think about challenges for implementation, we have to think about it in a systematic way. Starting right at the national level, how is that strategy, how is that information being translated into the operational environment? Once that comes to the operational environment, those challenges then are at a very tactical level. Do I have logistics? Do I have staff in place? Are there trained and capable resources to deliver this MNCH program? And all of those factors come into play. Again, having a very cohesive strategy, one that's very clear, and a plan that says this is what we're going to do by when, really helps to motivate staff, but also provides them with the clear picture. And that brings me on to my final point. And as I've been listening to comments, I've been looking at the chat box as well, organizational culture really comes into play. If we move into implementation without understanding organizational culture, or how a culture learns, linking to the learning system, or how a culture responds to data systems, we really are not embodying a comprehensive understanding of our system, and that impacts on our ability to implement. So I think in summary, understanding our system and organizational culture, thinking about the system constraints that we have in a way that we can start to unpack those and look at those individually, if it's resources, if it's human resources, if it's logistics, etc. But then also thinking about how we can sustain improvements. I think those are the main challenges, but also barriers to improvement. Thank you.
Great. Thanks a lot, Minara, for that. And I would actually like for you to also take on my next question. So please bear with me. This is related to on-site support, which we heard is specifically important for progress and to ensure that linkages from the subnational to facility level is functioning. So the implementation guide also mentions a lot of useful resources which can be used for various types of activities. But in terms of setting up on-site support structures at subnational and facility level, what materials and documents have you been used, and what would be the added value of this implementation guide?
Thank you for that question. So on-site support is, without on-site support, implementation fails. So that's the very first point. What does on-site support look like? It can begin with capability development. It can begin with training, but really training alone doesn't work. So for that service provider, if we imagine the number of trainings that somebody goes through within their lifetime, do they really understand the impact of all of those trainings? And I think that's really key in this process. When we think about on-site support, let's think about training. Impact of training. And we also need to think about concepts such as coaching and mentoring, which really help support and guide teams and service providers on how best to move ahead with improvement, which is, to be honest, a very complex and time-consuming task. So in terms of guidance, the existing WHO framework and the standards, the MPDSR toolkit, there are very many toolkits that really help us with implementation and help us think through the how. And each one of those documents have supported certainly countries and organizations to help with that implementation. In Bangladesh, we developed, and I had the opportunity to work in Bangladesh for a number of years, we developed clinical bundles as the intervention packages, and there are 17 clinical bundles which are implemented in over 200 facilities now. But the foundation and the basis of that were the standards and looking at the experience and the provision of care. And that's the guidelines that we use to design those bundles. When we think about implementing MPDSR, we also have a complete supporting structure which needs to be implemented at the on-site level, at the facility level. So really, when we think about all of that, let's think about the new guide. The new guide really, synthesizes everything, brings everything together, and comprehensively provides that approach to facilities. So the coaching and mentoring comes across as a really strong theme in all of this. And I have to say that the experience from Bangladesh and the clinical bundles, without that coaching and mentoring support, that really would be very challenging. And I think as we move through this journey, and certainly in Bangladesh, which is a USAID supported project, they've really helped us to support that work and to continue with the monitoring and coaching, which enables the implementation to sustain in the long term. I hope that answers your question.
Fantastic, Minara. Thank you very, very much. And we also encourage everyone to take a deeper look at the useful resources mentioned in the implementation guide. So earlier we heard Kathleen talk about the key components and importance of a functioning measurement system. So to build on that, it would be very interesting to hear more about how we can ensure data is flowing from the point of care and upwards through the health system. So the implementation guide highlights the importance of quality of care measurement system at subnational level and also the point of care. So what are the opportunities and challenges in setting up a subnational quality of care measurement system, which includes bringing information from the point of care up to the national level? Kathleen.
Thank you very much for your question, Martin. And I think we've already heard some wonderful examples of creating a subnational quality of care measurement system that informs national governance and learning from Ghana and Ethiopia. And I'll just highlight a couple of additional points. I very much appreciate the fact that the implementation guide emphasizes and advises the development of a regional and district quality of care measurement system. And I think as I mentioned previously, the network monitoring framework, which is also incorporated into the implementation guidance, includes 4 categories of indicators targeting, different actors across system levels, which are highly relevant at the subnational level, including core measures that are relevant across all levels and all stakeholders, district performance measures, QI measures for use by frontline QI teams, and program process measures for use by quality of care program managers. And all of these categories are very relevant at the subnational level. So in addition to monitoring nationally designated core measures, the implementation guide highlights the importance of a regional or district level quality of care operational plan. And this plan defines regional or district specific improvement aims and specific quality of care measures based on local burden of disease, local quality of care gaps, priorities at the subnational level, as well as findings from a district level MNCH quality of care landscape analysis as highlighted in the implementation guide. So for example, if postpartum hemorrhage, newborn asphyxia, and pediatric pneumonia are known or measured to be or assessed to be leading causes of morbidity and mortality in a district, the district may decide in initial phase to prioritize improvement aims and specific quality of care measures related to improving these conditions. And so this might very much inform a regional or district level quality of care measurement system. And as noted in the implementation guide, data on patient outcomes and processes of care, as well as people's experience of care, enables district managers to understand learning facilities' progress in reaching selected aims, and also helps them identify facilities that are really demonstrating improvements in care and can share with other facilities, as well as targeting facilities that need additional support. So for example, in Sierra Leone, the National Quality Management Unit has worked closely with district managers and stakeholders to define district and facility-specific improvement aims and aim-specific quality of care indicators, and in turn to provide ongoing support to district managers, facility managers, and QI teams to regularly monitor and analyze trends and prioritize quality of care indicator results to determine whether or not care is improving. And these sites and districts are generating the kinds of run charts, time series charts that were shown by our colleagues from Ghana. In Nigeria, multiple states have also developed state quality of care operational plans that includes a monitoring plan and a set of priority aims and aim-specific quality of care indicators. And on a quarterly basis, the state quality of care MNCH technical working group share the results of the core agreed MNCH quality of care measures with the National Quality of Care Technical Working Group. And this technical working group at the national level regularly reviews results across states during quarterly meetings in which state representatives participate, and that helps to inform learning and also oversight at the national level of large-scale quality systems. I'd like to just end my comments briefly by highlighting 2 challenges. I'll be very brief. And one is, and I think this was emphasized in many of in the country presentations as well as by other panelists, that there's an enormous need to build capacity of stakeholders across system levels for quality of care in general, and also specifically to be able to define meaningful quality of care measures based on local priorities, and to collect, analyze, and monitor trends in these quality of care indicator results to inform continuous quality improvement at the front lines and to inform subnational management of large-scale quality of care efforts. And another challenge an opportunity I'd like to mention is the importance of building fit-for-purpose health information systems, for example, facility registers, patient charts that capture individual client data, which we know is essential for both clinical point of care decision-making and for regular monitoring of quality of care to guide continuous improvements in care. And this is an area that I think is recognized as really critical to being able to use data on a regular basis. And striking that balance, this is my final point, between not too much and not too little quality of care measurement, not too many indicators, but just enough indicators, is really a challenge and an opportunity, and to me represents the sweet spot that we're still trying to achieve in many settings. And this is an area where I think districts and countries can learn a lot from one another and will be a continuing journey. So although many challenges remain, I think this is a very exciting moment for quality of care, including for quality of care measurement. Thank you.
Thank you very much. That's really great, Kathleen. Just to acknowledge that we know we're running over time, but there's still a lot of people on the webinar, so we will go a bit longer. So apologies for that. So let's move to the next one. So traditionally, we assess the quality of care system in two ways. Firstly, the processes and outcomes that Kathleen just mentioned. And secondly, also measures that account patient, family, and community satisfaction and the experience of care. So beyond just assessing the assessment for quality, engaging patient, families, and communities is increasingly recognized as a key component of planning and delivery of quality health services. So now I would like to go back to you, Alex, to understand a bit more on what is your experience in implementing community engagement interventions for quality improvements?
Thank you again, Martin. My response is it's been rewarding, depending on the way you go about it. So in one of the UNICEF implementing countries, in a community engagement session, somebody had a family member visit from the city and heard that the facility needed a standby generator for their new operating theater. The relative from the city offered to buy it and put in a revolving fund to generate money to be able to fuel the generator for as long as it's going to be working. This is a direct benefit of a facility not afraid to expose themselves to the community, but in the spirit of transparency, wanting the community to feed back into what they are doing there. So as I said, rewarding. But the question is, who is community? We always see ourselves as health workers and other people as community. But you are only a health worker when you are in the health facility, because when you leave the health facility, you are in the shopping malls with them, you are in the churches with them, your children attend the same schools with them. So you become community. So sometimes we think about community just as people outside the health service, but it involves a lot more. Other health workers who are not working in the unit are community. Other local champions in the community are community. Even orderlies that you think their work does not directly relate to care provision are part of this community that we need to continually engage. And in my experience, I think that getting all these people on board has been useful. But as I said, engagement must be purposeful. There must be why you should engage. You should know why you want to engage the community. You must see the community as equal stakeholders in the quality care that you are providing. And for that matter, you must give them a platform to talk to you. And talking to you means that, like the Ghana example of the scorecard, let the community come and appraise what you are doing. In a spirit of transparency, accept what they tell you. Whether it makes medical sense or not, that is the feeling of the community about the work you are doing. So accept it and see how you can make modification to make the community happy. And then the other thing is that you must listen. You must listen. Sometimes we are health workers set in our perceptions, thinking that this is the way healthcare provision should go. But as far as I am concerned, as a user of the healthcare, there is always my experience, and that is what I'm thinking about, not what you think it should be, but what I want to get out of the service. So I think that community engagement should be something that must be purposeful. It must clearly be an engagement of the community, not just outside the health services, but it should also be within the health service delivery. The third thing is that it must involve providing the community a platform to input into the work you're doing, and then you must be ready to listen to the community. And when the community see you as equals and they see you as open, wanting to let them know what you are doing for them, and then to receive from them what they feel about what you are doing, it brings that level of understanding between you and the community, and progress is what you can get. So I think in summary, community engagement is always, always rewarding, even though there are risks, but be ready to accept when you fail and the community bring it up. In preparation for community engagement, which is the last thing I want to say, you need sometimes to go into the community to pick up some perceptions they have about the care you are giving. So before they start raising them in the forum that you're engaging them at, you bring it out and say that we know that in the community, there are perceptions that we do this, we do that, we do that. But then find a nice way of engaging them and letting them understand why some things you do are not accepted by the community. And also, frankly, accept in front of them that you have failures, but you are also learning, that you want them to input into your learning to become better for them. That's what I would say about that. Thank you.
Thank you very much. Thank you very much. Excellent and very interesting, Alex, for that sharing. So now I will pose my last question for this panel discussion. And we started off with Shams talking around how the implementation guide for MNCH links with the whole broader QoC guidance and the PHI agenda. And we also heard more from others on different tools and documents and resources that's kind of been instrumental for setting up a quality of care system. Now, this implementation guide aims to bring together a full view across the 3 levels of the health system and be a valuable tool for countries and implementing partners. So my question to Shams is how this new implementation guide for quality MNCH complements other tools that have recently been brought together in the new quality of WHO quality toolkits.
Yeah, thanks very much, Martin. And I've really enjoyed listening to my fellow panelists on various aspects of this work. So I know time is short, so I'll keep it very brief. It's so important to get the right information, the right tools to the right people at the right time to save lives. So the WHO Quality Toolkit is an imperfect product, and I say that publicly, but it is the first time that WHO is bringing together all of the tools related to quality of care from different programs, from health systems, so that the user, you, can access WHO tools in one place. We'll share the link with you. And the important part of this is when we take a view on quality of care from a specific population group, which is absolutely vital, we at the same time need to think about quality of care for TB, for malaria, for HIV, quality of care from a purely systems perspective. And of course, and Kathleen is very eloquent in the way that she describes this, the linkage with the measurement dimensions and the measurement thinking. So the WHO Quality Toolkit does that in one place, and particularly the linkage with the primary healthcare measurement framework becomes critical to consider. So all of these pieces within the jigsaw, we've tried to make it accessible for you. Pivotal to that is the focus on quality of care for maternal newborn health. I'll make sure that I put the link into the chat. I know time is short, Martin, so I'll keep it at that. Thank you.
Thank you very much for that, Shams. And a huge thank you to all the panel members on these excellent insights from their experience working on different aspects of the quality of care programming and implementation. We decided that we will still have a lot of people on the webinar, so we will go for a few more minutes. We've received a lot of questions, a lot of interesting questions. Obviously, we just have to pick a few of these. So 2 to 3 questions we will do. So if we still have our colleagues from Ghana on the call, we would like for you just to reflect a little bit upon a bit how we saw this wonderful quality improvement initiatives and projects. So how do you work now to sustain these QI gains that's been made?
Okay, this is Fred. Can I answer?
Please go ahead, Frederick.
Okay, so there are a lot of lessons that we have learned from the inception of the program, and one of them, which really helped us to reinforce the national health quality strategy, was the training of work improvement teams. The training of work improvement teams. Initially, quality was kind of seen as only national, regional, and maybe district. But to the point of care, if you take a hospital, you can have about 16 departments. And these 16 departments, for each of the departments, you can train work improvement teams to be part of that department. So that quality is no more the work of only a core group in the hospital. But each department, you have a core people who have been trained as work improvement teams who will be able to address the problem, and they are part of the bigger hospital. So that is what we are doing. And not only that, initially, people saw quality as an afterthought. So even when they are part of the work improvement team or quality improvement team, it's like when they come to work and after they have finished, let's say, their core duty as a midwife, then they will start looking at the data. And that becomes like a secondary work or additional work. What we are moving towards is that when you draw a program and the work improvement team is supposed to have a session to do whatever they want to analyze problems, develop change ideas, you have to relieve them of the duty so that when they come to the hospital, that work improvement activity they are going to do is part of the core work. It's no more seen as a secondary, it's core. If they're able to analyze, do a change idea before they are scheduled for the day, they go back to the work. So you're having a bigger number involved in this, and it's part of the routine that they are supposed to do. So it's no more seen as an additional work, it's seen as your work. And not only that, we have incorporated that into your performance agreement, performance contract, appraisal, so that at the end of the year, you are appraised on them as your key deliverables. In this way, when you do it, it's part of the bigger work that you are seeing. And this is translated into the next level. Medical soups or medical directors are appraised on that. District directors are appraised on that. Focal persons are appraised on that. In that way, you are seeing that subnationally is becoming part of the work that you do, and you sustain it in that way. These are some of the things that we are doing to make sure that it's part and parcel of the work that we do. I think if other colleagues can add.
Yeah, no, thanks a lot, Frederick, for that. It's very helpful to get those insights. And a lot of the questions we received, it's about sustainability and scaling up. So Maybe if I can pose a question to our Ethiopian colleagues on how particularly leadership can be sustained at the different levels of the health system. What's your experience around the sustainment of the leadership for quality of care? So if you are still with us, Sister Yamela.
Sorry for that delay. About the leadership, there is a commitment for leadership, from leadership to implement quality improvement initiative. Not only MNH, other initiatives also implemented through Health Service Quality Directorate. To sustain the MNH quality improvement initiative, we have already established QI structures that implement all QI activities in at national and subnational level. So the sustainability will be good, and it will be sustainable for even if the national the national support out of that area, the initiative will be continued. There is a structure, QI structure at national and subnational level. So there is no problem to continue the initiative. There is a policies as well as directions, guidelines, and the capacity of the quality improvement team at health facilities built. So I think the sustainability is not this much a problem for us. Thank you.
Oh, great. Thank you very much, Sister Nalem, for that. And maybe if we can also turn to Ghana, to Selina, what's your take on that? How in Ghana have you found the experience of sustaining the leadership for quality of care at the different levels of the health system? So Selina, if you are still with us. Okay, it seems that Selina is not getting this. So, okay. Yeah, Selina, are you with us?
Hello, may I take your question again, please?
Yes, sorry. We would just a question around how to sustain leadership for quality of care at the different levels of the health system. How have you in Ghana, what's your experience and what's your take on this in sustaining the leadership for quality of care?
Thank you very much for the question. So the leadership aspect is very important for us to be able to sustain what we have gained. At the ministry in Ghana, what we have is that in our national healthcare quality strategy, we have stated leadership from the national to the sub-national. So where we have also a national quality technical committee who meets quarterly to also give an account of how they have implemented the quality activities in their various agencies or facilities. Again, trying to also make it that leadership will take an account, will be accountable for all quality activities that has happened in their various agencies and update the ministry level. So leadership aspect is like they are giving them an authority or the will to be able to implement it and account for at the national level. So all agency leaders are supposed to account on quality issues at the national level. So I think if we continue with that, then implementing or sustaining the quality of care, what we have achieved so far, will not be so difficult for Ghana to be able to achieve, because it's spelled out straight ahead in our quality, national quality strategy as leadership and commitment to quality activities, and leaders to be accountable for quality activities in their various agencies and then the facilities. So I think sustaining it might not be very difficult for us, because we have already started things like leadership commitment into the implementation of quality activities. Thank you.
Thank you very much, Selena. And I think that's wraps up this webinar launch of the implementation guide. A big thank you to everyone that presented. It's been a privilege to have you sharing your lessons and experience with all the participants. A big thank you for everyone who participated and the active communication and engagement in the chat box. It's really good to see. I think based on we had to move 30 minutes over scheduled time, but there's a lot of interest around this, and there's still a lot of work to be done. Please, we really encourage you to take a look at the implementation guide and all the related documents and tools. And we hope to see you all again soon, and to continue our work to improve the quality of care for maternal, newborn, and childhood. Thank you very much, and wishing you a lovely day and evening ahead.
Thank you.
Thank you.